Hello and welcome. In this video, we will be discussing thyroid function and testing. When thinking about the thyroid hormone, it is difficult to look up a textbook and say, what is the target receptor and the target tissue for thyroid? And the reason for that is that it goes to the nucleus where it has response elements. It targets the nuclei of almost every cell. And the reason for this comes from the evolution of thyroid hormone, which evolved initially for the development of central nervous systems, and then was later adapted to develop from exotherms, who derive their body temperature from the outside environment, to becoming endotherms. And endotherms require metabolic changes in their body that are regulated by the thyroid hormone. So a good way to think about thyroid hormone is to go to our bioengineering model of the human body. And in this, any biologic function requires a specific dynamic range, which is the optimal conditions for performance. And in that, the ideal is called the set point. To keep the body within the dynamic range of temperature requires a sensory mechanism. And in the human body, sensation of temperature occurs mostly in the skin, on the palms and the soles. So that if you're in your house and you wear gloves and socks, in fact, you can keep your house much colder than you would guess because the warm hands and feet condition the body to think that it is quite warm. There are other sensors in the spine that report to the brain, and then there is direct measurement within the hypothalamus itself. These sensors report to a central controller, which in the human is in the hypothalamus. And the hypothalamus then regulates the temperature through its effector mechanisms, which is the sympathetic nervous system. The sympathetic nervous system regulates temperature through the skin, both by vasodilation and vasoconstriction of blood vessels, and by the performance of sweat for cooling through evaporation. As well, it affects changes in the muscles, and this includes the muscles of the heart. The ideal set point for most humans is 98.6 degrees. It isn't clear why that is the set point, but it is a widely variable number within different groups of people. Across a population range, the ideal set point of any given person's body temperature is plus or minus 3 degrees Fahrenheit. There's a distinct diurnal variation, so that the body is 1 degree cooler at 4 a.m. in the morning. Hormones change it. When females have an increase in progesterone, in secretory phase, it increases the core temperature 0.4 degrees Fahrenheit. Cytokines, particularly IL-1, increase, and that's what we call a fever. Cortisol, the anti-inflammatory, has the opposite effect, and it decreases body temperature. So when you think about the normal body temperature, you have to have wide allowances for individual variation, changes through the day, and then individual circumstances in which the person finds themselves. How does the set point create a warm body? How do you create internal body heat? And the answer is you do that through the basal metabolic rate. This is a complex term, and when you find out, well, what really happens at the molecular level to change heat, you do this by increasing the activity of anything that is energy related. So at the cellular level, the first thing that one can do is one can create a leaky cell membrane. The electrolyte balance of a cell is set by the sodium-potassium ATPase. So with a leaky membrane, you have to have increased activity of the ATPase, and that creates heat. The mitochondrial inner membrane is where we find the electron transfer chain. So if that becomes leaky, then we have uncoupling, and that creates an inefficiency of ATP production. Another important ATP pump is the smooth endoplasmic reticulum calcium ATPase. And note that this is found in muscles, both in the skeletal muscle and in the heart. So if one creates a leaky membrane in the smooth endoplasmic reticulum, there has to be an increase in that ATPase. And there's a price to pay for that. If you compare the energy needs of an endotherm compared to an exotherm, it increases the energy needs tenfold. How does the thyroid regulate this? Temperature regulation can either be helping out when it's too hot or when it's too cold. And when the hypothalamus detects that state, it creates circumstances that sheds heat or keeps heat. If a person finds themselves too hot, affection through the sympathetic nervous system is going to cause vasodilation of the skin for radiant heat, and if that is inadequate, then the body will sweat and cool by evaporation. If the body is too cold, again through the sympathetic nervous system, the hypothalamus starts by inducing vasoconstriction of the skin, and if that is inadequate, then it stimulates muscles and generates heat through shivering. In babies, there's a special adaptation with the protein thermogenin, which creates uncoupling in the mitochondria, and that generates its own heat. The obvious ClinPath correlation of this is we can see that thyroid disease is going to have relationships to this function of temperature regulation. The first is going to be sympathetic nervous system interacts with the muscles, and that includes the heart. In thyroid disease, we will often see weakness, muscle atrophy, and in the heart, arrhythmias. Relationship to temperature is also very closely related to thyroid disease, in which one has either heat intolerance or the patient perpetually feels cold. Basal metabolic rate is calorie using, so there is a close relationship between thyroid disease and body weight, with weight loss despite increased appetite in hyperthyroidism and weight gain despite dieting in hypothyroidism. And then lastly, the fact that the thyroid works through the sympathetic nervous system. And these are some of the most troubling symptoms for patients that have thyroid disorders. These include anxiety, tremors in hyperthyroidism, and slowness and dullness in hypothyroidism. So thinking through the thyroid as a temperature regulator function and how it does it by regulating cellular ATPase functions is actually a good way of thinking what your patient's going to look like. Endocrine systems are feedback mechanisms. So when we think about how the axis works, we start with our standard picture with the hypothalamus going down through the median to the plexus of the thyrotrophs, and then that affecting the change to the thyroid gland. So the hypothalamus produces thyroid releasing hormone, the pituitary releases TSH, and the thyroid has negative feedback with T4. Thyroid disease is primary, pituitary disease is secondary, and hypothalamic disease is tertiary. Thyroid hormone synthesis occurs uniquely by producing the hormone into a center colloid mucinous structure. So if we took a look at the structure of the thyroid, we would see it has these sort of pseudoglandular-like structures in which the individual thyroid cells release into this central colloid as a storage pool. In looking at individual thyroid cells, all thyroid activity is regulated by the TSH receptor. It increases the activity of all functions within the thyroid. This includes the production of thyroglobulin, which will be increased and dumped into the colloid. Sodium uptake is through the sodium iodine symporter, and the iodine goes through again into the colloid. Within the colloid, the next steps are to create active iodine with thyroid peroxidase, and that organification is then followed by the coupling of the iodine to the thyroglobulin to create DIT. For release, the DIT has pinocytosis into the thyroid cytoplasm where it's combined with a lysosome. This clips the thyroglobulin and creates the T4, which is released into the blood. T4 is highly bound, mostly by thyrobinding globulin, but also with transthyretin and albumin. There's very little free T4, the actual active component, so one should always think of the T4 bound in balance with the free T4, which is the active component. When we take a look at the clinical correlation of learning this biochemistry, the sodium iodine symporter can be used when there is radiation exposure. Anyone practicing near a nuclear plant where there's a chance for radiation exposure can issue supersaturated potassium iodide, which will block iodine uptake through the symporter by supersaturating it ahead of time. Note that the TSH receptor is the target of an immunoglobulin in Graves' disease. Both thyroid peroxidase and thyroglobulins are proteins unique to the thyroid, and so they can be used as measures of thyroid disease. As well, TPO has a critical metabolic function in the thyroid, and so it becomes the target of thioamides, the most important of which is methimazole, when treating hyperthyroidism medically. So how does thyroid actually work in the cell? If one draws a cell membrane, remember that it is highly bound, so it is only the free T4 which can pass into the cell. There is a thyroid channel, but within the cell there is a unique metabolic change in thyroid because it is metabolized by a family of enzymes called the deiodinases. And there are three major deiodinases, types 1 and 2, which will convert the thyroid into the active T3 form. But there is also a deiodinase which can convert it into reverse T3, which is inactive. Now these deiodinases differ by tissue, so that each tissue, while exposed to the same amount of T4, will receive a different stimulation by it. And this is what is called peripheral modulation. Once it's in the body, the T3 passes into the nucleus, where it is bound to thyroid receptor in a complex with retinoic acid receptor. Bound to this, then, the T3 will affect with the response elements of the DNA to create its effect. A number of things to note. It's the free T4 that's metabolically active. So when you have situations in which there's an increase in TBG, such as pregnancy, it can appear by routine lab testing to be a hyperthyroid state, when in fact the person has a normal T4 and is euthyroid. In disease, one can see a shift of the deiodination to reverse T3. This means that thyroid testing is actually not clinically useful in situations of acute illness. So how does one test for thyroid disease? Well, first, as always, there's the patient encounter with symptoms in the physical exam. The problem with using these is that it is both insensitive and very non-specific. If one does clinical studies, only 40% of overt thyroid disease is recognized by history and physical. If one takes a look at all your patients that are over 60 years of age, 10% of them will have overt thyroid disease, which is mostly hypothyroidism, and that will not be recognized by history and physical. If these are so limited, then everybody screens for thyroid disease, especially in older people and especially in females. And one of the strategies to doing this is to do a TS-only testing strategy. And that makes sense. We have the hypothalamus, TRH to the pituitary, TSH to the thyroid, which inhibits with T4. So the TSH becomes an excellent measure of the feedback system. There are, however, a number of problems with this. The problem is because everyone has a different set point, there's a wide reference range. It's very hard for laboratory to give you a very tight range for any given patient. The second is, remember, thyroid drops at night, so that there's a decrease of the TSH by 50% when you're asleep. In illness, the hypothalamus shuts the body down, and so there's also a decrease in TSH in ill patients. And lastly, lots and lots of medications affect TSH, and these include most of the medications one sees in autoimmune disease, including steroids, but many others. So if you're in an outpatient setting with a perfectly well patient, everything's stable, TSH is a really good screening strategy for thyroid disease, but you have to do it in the appropriate patient. A better way of doing this, although more expensive, is to do both TSH and T4, because they have inverse relationships, a high TSH and low T4 and vice versa. This works very well, and in fact studies have shown it's proportional to the free T4, which would be the best test, but is hard to do and quite expensive. The limitation of this, of course, is that this is a blood test, and we know because of the deiodinases that really it's the cell function of T3 that's going to be the true measure of thyroid status, and we just don't have a test for that. The other thing to think about when you're doing a TSH and T4 is you'll often see the situation of subclinical thyroid dysfunction. And these are patients in which you're going to see an increased TSH, but a normal T4. And this is a well-known problem area in medicine that's widely argued over what one should do, but what everyone does agree is to try to interpret this, you need multiple data points so that you can follow a trend. And the only area of consensus of who one should be treated should be women who are trying to get pregnant, so as a fertility issue, and women who are pregnant. After that, it's left to the individual discretion of the clinician. Thyroid testing has a number of analytes that have different indications and interpretations. So when we say TSH, single TSH, that's a really good primary test and probably the commonest thing you're going to see in outpatient practice. If it is elevated or decreased, this is really good for primary thyroid disease, meaning the disease is in the thyroid gland where most is found. Remember, it has a number of limitations. It is highly variable by given individuals, so there's a wide reference range. There's diurnal variation, so you can't get up in the middle of the night to take the test. Remember, it goes down in illnesses, so you can't do it in sick people. And then last but not least, if your patient is on medications, they can affect the test too. T4 is also a good primary test that's done really well when you do it together with TSH. Interpretation, hyperthyroidism. The biggest problem with it, remember, is high binding to TBG. So when we talk about pregnancy that can increase TBG levels, it's not a great test. Free T4 is an excellent test because it has no TBG effect. So most of the time it's going to be used in pregnancy when you're not sure how to interpret the T4 because the TBG is elevated. The problem with it is technically difficult. And you're going to find it varies between labs, and the results are hard to compare between them. Total T3 is useful for a very small number of 5 to 10 of hyperthyroid patients who have a T3 toxicosis. And these are going to be patients in which you see a decrease in TSH, but a normal T4, and clinically they appear to be hyperthyroid. That would be an excellent time to order your total T3. If it's elevated, that would be a T3 thyrotoxicosis. Remember, the problem again is T3 in the blood is carried on TBG. Thyroglobulin has two uses. It's a very good cancer marker for follicular carcinomas, and it's also a good marker of factitial hyperthyroidism because TBG is associated with natural hyperthyroidism, but it's not part of synthroid. So in interpretation, if thyroglobulin is up, an increase in thyroglobulin is associated with hyperthyroidism. Anti-TPO is a great test in Hashimoto's thyroiditis because TPO is a protein specific to the thyroid. Anti-TSH receptor antibodies are positive in Graves' disease, and TRH injection is now an outdated test. Before we had third and fourth generation TSHs, but obviously one could look for it in secondary and tertiary disease. So that brings us to the end of this video. Thank you for your attention, and we look forward to seeing you next time.